So the last speaker for this session is Dr. Kah-Whye Peng from the Mayo Clinic, and she will be talking to us about non-invasive imaging technologies to monitor biodistribution, activity, and toxicity of viruses and cell therapies.
Well, good morning. Thank you so much to the committee for this opportunity to talk about some of the work that we have been doing at Mayo. It's a broad spectrum of technologies that is being monitored here. And I do have a disclosure. Myself and the Mayo Clinic have a financial interest in the technology that will be described as the NIS technology. And it has been licensed to Imanis Life Sciences. I'm a co-founder and employee of Imanis. And for folks who know me, I'm a virologist that developed oncolytic viruses for cancer. And they're like, what are you doing with a reporter gene company? And it all started is because we wanted to track the fate of our viruses. These are replication-competent viruses in our cancer patients as we dose escalate in our trials. And investigators start to ask us, can we have your NIS reporter genes? So we founded this company, Steve Russell and myself, to enable this technology to be used more widely to facilitate the drug development of each one who was interested in virus and genes. So I think many of us are quite familiar with imaging, and we have seen a seismic change in this demand for imaging to see more with less cells. We have been telling folks to use reporter gene imaging to follow fates of cells and viruses for a long time. And I think only in this year, and especially at this ASCGT meeting, that we have seen a very transformative interest. People are now starting to be interested, where do the cells go? But there's a demand for this technology so that you could track the cells and viruses in living subjects. We want to track them longitudinally and ideally quantitative, and it be sensitive, and it be high resolution, and ideally applied from a mouse to translational animals and to the clinic. Very important to think about resolution and penetration. Microscopy, fluorescence, we are very familiar. It allows you to look at cells with exquisite resolution, cellular analysis, but it's only skin deep. So you cannot penetrate more deeper than a cell layer. Bioluminescence has been fantastic in my studies. However, it is also limited to the surface. For folks who want to go into the translational animals and eventually to clinic, you have to use other modalities which are listed there, ultrasound, and going deeper into the MRIs, the PET and the SPECT and the CT allows you now to move into the deep tissues without loss of resolution or sensitivity. So I just have a little test. So we have animals and identify the PET tracer and the animal shown left or right. Can anyone guess what is the PET tracer that's been used and what are the animals? Maybe let's start with the animals. The animal on the left, what do you think it is? Anyone? It's a large animal. Dog, and then on the right? Human. So the PET tracer is actually F18 tetrafluoroborate. And the protein that took it up is the NIS. You see the thyroid, the salivary glands, and the stomach. That is the physiologic uptake of NIS, of the TFB tracer. In the 80s, when we come to the gene therapy meetings, we are very familiar with the blue organs with the LAC-Z beta-galactosidase reporter gene. It has been really great. But we require us to harvest the animal, kill it multiple time points, and stay in the tissues. The GFP allows us to do high-resolution analysis, but also killing of the animal. And luciferase, firefly luciferase, actually we celebrated the 20th anniversary in 1995 since it's patented, but it came from the firefly, so it's immunogenic. But allows you first time to see in mice and has really captured the imagination of people. Everyone's using luciferase. Now we have moved into the era of deep tissue imaging with high resolution and with radioisotope imaging. Regardless of what isotope, you are able to obtain tomographic images. And this is in a living animal, and you can repeat it over time. And optical versus radioisotope imaging is quite clear in this left and right comparison of luciferase. This is AAV9 IV gene transfer into a mouse. You can see The luciferase allows you to do sensitive, high-throughput screenings. But with radioisotope, it allows you to do high-resolution imaging. And if you can see here on the animal, it's quite evident with AAV9, it transduces the heart. But little do you know that there's an off-target transduction at the back of the animal, and that is the brown fat. So areas that you may not expect to attain allows you to rapidly now look at the whole animal at a time point and obtain really great data that is giving you spatial information of relative location of all these tissues that's expressing it, and allows you to move from a mouse to a human. So what is NIS and how does it work? It is a cell protein in the thyroid of all mammals, and it traps iodine for the synthesis of thyroid hormones. And when you give it a radioactive iodine, for example, 123, it will uptake it and goes into the cell with sodium. The sodium iodide symporter. And now the cell will light up with a radioisotope tracer, and you can now observe where the location of your cells are. And here's a bone marrow transplanted cell, mouse with cells that are expressing NIS. And the physiologic uptake of this tracer is well defined. This is the human and the mouse. Again, you can see the thyroid, the salivary glands, the stomach, and the excretion of the isotope through the bladder. And this is 123 scan. And there are various tracers that you can use, a PET or a SPECT, depending on what your institute has. Many of us have, in the clinic, there are PET and SPECT tracers readily available, and PET imaging also gives you much higher sensitivity, almost 10 times higher sensitivity. There's a whole spectrum of gamma isotopes that you can use depending on your indications. You have long-acting or a short 6 hours half-life technetium pertechnetate. And two of our favorite tracers that we are using quite a lot in our human studies and mouse studies are the technetium pertechnetate for SPECT imaging or the TFV for PET imaging. So I'm going to go on to show you a whole series of data that we have obtained in collaboration with our key opinion leaders who are developing virus and gene and cell therapies. And I'll showcase the study from Imanis Life Sciences, AAV gene expression, biodistribution, and this work from the team shown here, unpublished data. So first of all, we want to kind of express to everyone that by measuring the uptake of the radio tracer, it is correlated to the cell number. So the NIS is expressed by the transduced cell, and when you add radioisotope, it will take up the iodine or whatever tracer you are using, and as you increase the cell number, the CPM, counts per minute, increases, as does in vivo. This study design is quite simple. AAV9 under KEG promoter driving NIS, and given IV to a mouse, and when the animal is to be imaged, the tracer is given intravenously, either SPECT or PET tracer, and depending on the budget, you can image it as frequently as you like. And in a human scan, it's a few $1,000s, clinical scans. So this is the image of the mouse that is on the right. That is given IV AAV9 under the KEG promoter. You can see that the gene expression is actually in the heart, in the liver, and you can actually see that there is a transduction of the muscle, excretion of the bladder, excretion of the isotope to the bladder. This is the control animal, it's clean, but importantly, we like to show you that there is a gonad transduction that now allows you to monitor over time. You need to monitor semen in the AAV trials. So this is, allows you also not only longitudinal imaging, tomographic data allows you to quantitate the amount uptake. So in a mouse, you can now slice through each slice of the animal digitally using your software, allows you to now take the region of interest and quantitate the amount of radio tracer uptake in each of the target tissues that are expressing NIS. This is the quantitation, the standard uptake value, and it shows that the heart wall, liver, brown fat are areas that have uptake, the isotope where the NIS expression is, as well as the muscle. This data that is quantitated by SUV uptake is correlated with traditional immunohistochemistry staining using an antibody against the NIS. What is the use of imaging if not to facilitate our work? You have seen beautiful talks this morning about various work capsids that we can engineer, various targeting strategies. Now you can rapidly screen 100 different serotypes, rapidly, 3 mice per group, longitudinally over time. Of course, it gives you mass action. You now know that by changing a promoter, this is an AAV1 with a liver-specific promoter, IV, it expresses only in the liver. In contrast, when given intramuscularly, you would not be able to transduce the muscle because it is driving this under the liver-specific promoter. Here, it can translate back out to the dog studies, Maggie Redfield data, where she's interested in cardiovascular gene therapy in the dog. It also allows her to understand and develop novel methods of delivery. Here, intracoronary perfusion of the vector does not result in meaningful gene expression of 10 to 13 vector particles. What she developed was then a spiral catheter that allows her to deposit the AAV vector on the myocardium, and using this dog, 3 dogs, she was practicing and developed her preferred method that she can now translate into the clinic using a very really kind of bringing to the forefront of the principles of the 3R: to reduce, to refine, and to replace. Oncolytic virus therapy is close to my heart, and this is work that we are doing on longitudinal imaging of virus infection in a tumor. And this is data from Shruti, Lakana, and Amber at Mayo Clinic. Viruses have the ability to target to tissues, to metastatic tumor, and ideally they can infect, spread, and eliminate the tumor. This virus encodes the NIS reporter gene as a means for imaging, and here is the mouse given with a subcutaneous tumor, and given the virus, you can see here the thyroid, the stomach, and a blob that was showing the infection of the tumor. That is a machine that we have, a gamma medical machine, but with new machines, the resolution is exquisite. Here's a flank tumor in the mouse, probably 1 centimeter, 1.5 centimeter. Over time, daily imaging showing the oncolytic virus spreading, and each of these is an infectious foci of various infected cells, and you can see that actually allows you to render in 3D the volumetric relationship to the total tumor burden, and actually there is an infectious void right in the center of the tumor in which the virus did not get to. Here is the translation study that we are monitoring as we dose escalate in the patients, where we could see an FDG scan. The arrows point to the FDG glucose avid tumors on the flank of a myeloma patient. At baseline scan for the NIS expression of this virus shows 0 uptake. At day 8, infection of the 2 tumors. Interestingly, they infect to different extent, and over time, 13 and 28, elimination of the virus infection by the immune system. We have moved on to comparing a SPECT scan, that was an iodine-123 scan, with F18 because it allows us much higher resolution and sensitivity. Here's a dog image that we've seen, and this is data from Team DeGrado, who have now made a very high-yielding TFV synthesis method that allows us to now do a clinical trial to compare the resolution and sensitivity in our virus therapies. Cellular regeneration is a big topic. This is liver regeneration work done by Ray Hickey, Scott Neiber, and Steve Russell in pigs and in mice. And their purpose is to allow us to do hepatocyte regeneration in the patients with inborn errors of metabolism. It gets characterized by deficiency of hepatic enzyme or protein, and often method, obviously, you could do a liver transplant, but due to the lack of organs, a potential therapy is cell therapy or gene therapy, where you don't have to replace the whole liver, but maybe 5 to 10% of the total enzyme or protein. And the model that they have used is the FAH transgenic animals, where they are replacing the FAH gene. So what they have done, the idea is that you can take hepatocytes from the donor, isolate the hepatocytes, lentivirus transduction, and deliver it to the patient. The proof of concept was first established in a HT1 transgenic animal, where they have used a lentivirus to deliver the transgene as well as the reporter gene into isolated hepatocytes and show regeneration in the transgenic animal because there is a selective advantage for the growth and regeneration. They have now shown that then these transduced hepatocytes, primary hepatocytes from the mice, do uptake the radio tracer. They validated in an in vitro uptake assay before they move on to in vivo imaging. Here's a SPECT, technetium pertechnetate imaging. It's a very low-cost isotope that you can get from the nuclear pharmacy. They synthesize it daily for their thyroid scans. And here's the stomach uptake and the regeneration of an animal that received non-NIS expressing hepatocytes. In contrast, if the cells have been labeled with NIS, you can now see very exquisitely with high resolution that the regeneration is patchy. There are hotspots, the clusters of the cells that have grown up, and you can see it in the mouse. And of course, not all the regeneration works so well. It depends a lot on the intravenous infusion of your hepatocytes. What they could do and follow over minimum number of animals is that the longitudinal tracking and the regeneration allows them, they got really interested in single areas of clusters, areas of homing, and at day 41 you see the section across. This is one mouse over serial sections of the clusters of regenerating liver cells. At day 85, same animal and more cells have grown up and expanded. They move on and took that idea to a transgenic pig model, and that data is published in Science Translational Medicine, where they have now done it in a pig. And to cut the long story short, the top panel shows you the animal that did not receive a NIS-labeled cell, and the pig that received the, obviously, you can now see the NIS cells regenerating in the liver. The liver is circled in pink, and the spleen is in white, and the hot spot is the stomach that expresses NIS for endogenous uptake of the radio tracer. This is a TFB PET imaging on a clinical scanner on a GE machine, and the cross-section confirms the regeneration. We have also collaborated with Cynthia Dunbar at the NHLBI because she's really interested in developing a rhesus macaque animal model for her IPS work, and to facilitate as a platform technology to allow IPSs so that when it differentiate into various lineage, you could follow the fate of the cells and regeneration. So what they have done is to insert the NIS into using the CRISPR-Cas9 system into a safe harbor into the IPSs in the rhesus. And this rhesus IPS uptake the radio tracer, and there's an iodine 125 uptake compared to the parental cells, no uptake. And they went on to form teratomas in the mice, confirming through Dr. Noriko show that the uptake by TFB that they have synthesized in their facility at the NIH, that in these teratomas that form, they can be imaged. And the exciting work that follows next is the differentiation into various organs into the rhesus macaques. Last but not least, I would like to highlight some of the work that we are doing into more and more challenging models. So over time, you have seen from the AAV biodistribution for serotype selection, high throughput screening, we have seen liver regeneration allow us to follow from a mouse in the liver, but as well as the oncolytic virus therapy, moving from a mouse to clinical scan. Now it's in bone marrow transplantation. What we are very interested in the hematology department at Mayo Clinic is areas of homing of this bone marrow transplant. Why are there hot niches where the cells go? And this is work by Lian Wen in my lab and Tim DeGrado and Lakana, and with great advice from Cynthia Dunbar, who, as you know, knows bone marrow stem cell transplants very well. So this is in animals, in mice, in syngeneic mice that are the recipients. They receive whole body irradiation. And then we have the donor mice, took the whole marrow, which is really a very inefficient way of doing it because you probably have to harvest 3 mice per donor into recipient. But basically, you take the bone marrow cells, isolate it, select it, scar positive, CD105 positive, transduce it with lentivirus vector, twice transduction, confirm NIS uptake and infuse it into the animal and use PET imaging. And these are the scans. We have compared it with luciferase imaging, and this is the data we see. We can see luciferase signals much earlier on, but over time, you can see that the resolution is rather poor. In contrast, you could now, in the various animals, we have an exquisite imaging that you can obtain with this NIS. We're still trying to understand what the data mean. The control animal is on the right, basically with no signal, and the other animals have been transplanted with the NIS-expressing bone marrow cells. What you can clearly see is the individual variability in transplantation and the homing sites where they have engrafted, lodged, and expanded. What we are trying to isolate and decipher, is it from a clonal expansion, or does it go and spread and we will replace the whole bone marrow? So, and there we're counting the various hotspots that are maybe preferred homing sites. What we're very interested to know is that if we were to irradiate the pelvis, do we now have a change and modulate the homing and engraftment? But what is important to know, and this really comes back to how many cells can you see? These are actually the mouse vertebrae that you are looking at. PET imaging allows you to have really high sensitivity, and using NIS, it allows you to have strong uptake. But there's a huge demand to see more with less cells, and what we are doing at Imanis is that we have a huge program. We are doing extensive mutagenesis of the NIS SymPorter protein in collaboration with the University of Calgary, modelers, and as well as Mayo Clinic, to really change the sodium iodide SymPorter with various mutations to really find a protein that will serve our purpose for maybe with different isotopes that are isotope selective. Maybe it could be blocked by perchlorate to allow us to have even better reporter genes. So the value of the spec data can be now translated, especially when you talk to the various groups and as for really understand the spatial differences and relationship. With the spec data, it allows you to render the data in 3D, and this is a 3D printed mouse that is on the left here, and the flash, which is data from the CT, is co-registered and printed out. Here is a recent data that we just obtained because we were frustrated with the number of mice that we need to harvest for the bone marrow transplantation. This is human CD34 cells from the bank that we have. These are frozen CD34 cells that we have isolated, and these are 3 weeks post-transplant into an NSG mouse that we are now able to follow the fate. And we are very excited to see whether this whole animal will regenerate over time, and this is early days yet. So in summary, I hope you have convinced you that non-invasive imaging should be adopted in our studies as we develop our virus cells and drugs. It allows you to quantitatively measure the change over time as well give you spatial data, and allows you to do longitudinal imaging. And it is very important as to practice and incorporate the 3 R's in our animal research, especially when we go into large animals. The 3 R's to remind each other of refine, replace, and reduce. This NIS reporter gene in our hands, we really believe that it's one of the best reporter genes that we have worked with. It is very versatile, it's simple to use, and it allows many people to use it because you already use it in the clinic. It has less issues when you think about it with regulatory approvals because it is a reporter gene that it has been used for 70 years for imaging of the thyroid disorders. We highly recommend the use of PET imaging using the F18 TFB or iodine 124 because PET imaging allows you to see with much better resolution in the clinical scanners, and the data is very sensitive and important. The clinical trial using TFB F18 has been completed and reported, so that is the start of incorporating into other investigation studies are ongoing. And there's a big program that we are developing at Imanis that we call the NIS Plus. I haven't talked about it here because I didn't want to confuse the data with the endogenous NIS that already gives us very good data. But what we want to do is to push now to develop a NIS that will take up better TFB, and better technetium pertanatate, because the NIST has evolved to take up iodine very, very efficiently. Can we have now a selective NIS? So in summary, it's a lot of work that is contributed by a large team. I'm very grateful to Imanis team, to Cindy Dunbar's group, and my collaborators at Mayo who have allowed me to share the data and work with them. Thank you.
So what's the resolution? If you would inject in the spine or brain area, could you follow it there? And for instance, ocular injections, what can you say about that?
Yeah, no, that's a very good question. I omit to, you see that I did not put any CNS imaging because it's not
very
ideal.
well noticed.
Yeah. This imaging is not ideal for CNS imaging. The resolution of imaging on a clinical scanner is probably close to 1 millimeter, less than that. So it's pretty high sensitivity and good resolution. So it depends on the machine. And the machines in the preclinical scanners are much better resolution as well. In some of the machines that we have noticed, the manufacturers are claiming 0.25 millimeter, which is really high sensitivity and resolution. But CNS, if you're interested, we can talk more about other reporter genes. We have thought hard about it, and a reporter gene that we recommend and have seen people done is the dopamine receptor 2. That works pretty good.
Thank you.
Hi, Bill.
Hi, great talk. Always a real question with the off-targeting issue in vector delivery is, what is the resolution, the fewest number of cells that you could actually detect? Because lots of times with the off-target numbers, they're rather low.
That's a very good question. I think this is really, it's always a limit of detection. With the NIST imaging, with TFB, the NIH groups, Noriko Sato has viewed, and she told me that it is about 7,000 cells in her hands in their animal scanning, so that is very sensitive. With the UK group, they have seen 500 cells in 200,000 negative cells. So that is the best data that we have seen. So obviously, it depends on how well your cells are expressing NIS to see at the location. So, but if you give me 1 million cells and it goes in and it distributes everywhere, you will now lose where your cells have gone because you cannot detect single cell. Is it suitable to say that I do not see a signal? Can I claim that it is not off target? You can't do that. I think even with PCR, there's a limit of detection that is different. So this has a much less sensitivity than a quantitative PCR would have. But it allows you to rapid screen. So it's using different technologies for different applications at different levels of the drug development. Thanks.
You were mentioning that this was an effective tool for targeting gene therapy drugs. I was wondering, you're saying the cell number correlates with the intensity. Did you notice any differences between different tissue types, like muscle or nerve or liver, in terms of the ratio of number of cells to the intensity?
No, this is a very good question as well. We have not evaluated deeply in this way, and it's not a way to target the gene delivery, so it is a way to image it, to see where it has gone. It's similar to the luciferase technology. So it's not a targeting, it doesn't target, although it is a way for you to target beta emitters and alpha emitters to kill the cells. A thing that I didn't mention is that it allows you now, after imaging it, if you have a teratoma, maybe it's somewhere that you don't want it to be, you can now give iodine-131, which is a beta emitter, to kill off the unwanted cells. It is targeted radiation therapy that is used clinically now for thyroid cancers. So coming back to uptake, for example, we have not isolated muscle versus from the heart versus the quadriceps and see whether there is a difference. I don't think so because it's a symporter. So it depends, I think, how many copies you have per cell that you have worked with.
It's a wonderful data. How safe NIS is in long-term studies to incorporate into the vector?
Safety, I think, it is multi-dimensional. I think it depends. We haven't seen So we have done various gene transfer to different organs, and the KEC is a very strong promoter. In a lot of studies, we haven't seen any undesired effects. So in the liver regeneration, where it's 100%, well, I can't say 100%, a lot of regeneration in the bone marrow, we have not seen any adverse events that happen. And the regulators are very familiar with the iodine scans or technetium, so that's the radio tracer uptake. One thing that's important to remember is that the radio tracer is efflux all the time. So it is a equilibrium. It doesn't get trapped. As the isotope decay over 2 hours, the radioactivity is lost. So using a short-acting radio tracer is important, and it gets efflux. So you'll lose it. It doesn't get retained or organified except in the thyroid. With the protein itself, I think there will be, I think if you express anything to very, very high levels to overexpression, there will be a negative effect. We just haven't seen it, and I don't know, but I anticipate if you express too much. Even aspirin is not good. Yeah.
Okay, great.
Thank you.
Thank you so
Thanks.
much. Okay, that closes our session. I hope you learned as much as I did. Thank you.